Zoll technology will guide you to meet the 2015 CPR guidelines. High-quality resuscitation on the move is achievable, and high-perfusion CPR is within reach. When it comes to helping you deliver high-quality CPR, no one offers you more than Zoll.
Okay, thank you very much. Can you hear me at the back? Not really. Level up. Can you hear me at the back okay? Okay, thank you very much. Thank you for having me, Sohail. Thank you, Sams, for inviting us for this lovely event every year. My name is Rahul. If there's any questions, just raise your hands. If it's a short one, we can answer it at that time. For those of you who've just come in from overseas, welcome to Singapore as well. Hope you enjoy the place. Most of the people on this panel don't like working in hospitals, you'll gladly see. We're more comfortable sometimes working in an environment not surrounded by many things. And it's a matter of changing your perspective and your attitude towards some things. It's not always about just the physiology. Sometimes it's more the logistics and the other things, and not just the critical illness that's at hand. So this is a picture of where I used to work a while before I came back. I'm Singaporean, but I left for a while. And this is Perth. Perth is a suburb, well, it's a city, small city in Western Australia. And this is one of the airports there. So I worked, a few disclaimers, for the Royal Flying Doctor Service of Australia in Western Australia for a couple of years during and after my fellowship. And I also fly sometimes for Hope Ambulance, which has a small division called Hope Flight, which does critical care transfers and repatriations from Southeast Asia and even East Asia. And I do something for them every now and then. Not enough, that is. So this is what office space for me looked like for a couple of years. This is a little bit different from what you're used to. It's not really an austere environment in the sense that I don't have to struggle when I go to office, but understandably so when you leave the airspace to somewhere else, and when you approach the actual criticality, things get a little bit difficult. And I'll go into a few problems that we occur, since we're talking about challenges, and I'll tell you the good things that happens as well. So I do a lot of disaster medicine as well, and I teach disaster medicine, and I'll throw in a little bit where the amalgamation of the two blended very well in our favor for once, and I'll show you a little bit about how these two combined in a good setting. So retrieval medicine is about grabbing a patient from one space to another. It doesn't mean that you just grab it and then you drop it off at the airport. It is a bed-to-bed transfer. When you grab someone from anywhere as a retrievalist, even in disaster situations, it's from their bed to the other bed, which might be definitive care, meaning PCI, or it might mean ICU, or it might mean the ED. So it's a complete bed-to-bed transfer, which means you take from one situation to the ambulance, to the airport, from the airport, in the ambulance, all the way to the bed or the ED. So a lot of my life in my career has been spent at the back of an ambulance, and I know how difficult things can get in a small environment. So the idea is that you don't let the level of care drop. If you're transporting a critical patient, you don't want a junior doctor to do it. You want somebody all the way of the entire transfer to take care of them in a similar fashion as you would in an ED to ICU environment. This is what a jet medically outfitted looks like, in case some of you have not seen it before. You can take 2 beds. This is not great, so I'm just going to point. So 2 beds with critical patients if you have to. Doctor sits here, nurse sits here, medical equipment behind, stowed away, because you have to have the weight of the aircraft sorted out. You get monitors and life packs over here, defibrillators on top, suction right at the top over there. You get all the infusion pumps lined up here, and you roll the patient out through the back door, which is open at the back there. So that's what a medical outfitted aircraft can look like. Every aircraft is standardized so that you don't have to change your philosophy when you go into, and the good services and the really good services make sure that all the equipment for every aircraft is the same. Okay? And that's how you look at it from that portion. So everything is like a mobile ICU. You can handle 2 critical patients if your nurse is very good. Otherwise, standard is 1 and 1 not so acute. So the idea of retrieval medicine is also never do anything on the way. The idea is to have a nice, stable transfer, and we're talking about the same thing when you transfer a patient from your ED to the ward or ED to an ICU or ICU to another ICU. It's the same thing. You do not want to be doing anything on the way. That's the idea. But that rarely happens. And the idea to package somebody involves a whole lot of things, and you require a whole lot of checklists to remember what needs to be done. So it's not just the pilot using checklists, it's us using the checklist as well. Because there's only so many things that you can remember at one point. And all or almost all of the adverse events generally happen when you're moving the patient from one point to another. Almost all the problems I've ever had is when we're transferring from the bed to another stretcher or a stretcher to the ICU. Almost always. This is what a view from the cockpit can sometimes look like. If you're nice, the pilot lets you fly from time to time, and you don't cause any other problems. This is a view of Perth, lovely city, and sometimes you get these breathtaking views with a chance. It also comes with problems. So when you fly up to a level such as this, you can imagine in a non-pressurized cabin. These are propeller planes, not all of them are jets. And even if it is a jet, it's not the same ambient partial pressure of oxygen. So when you get critical patients who are intubated or not intubated, their requirements are much, much higher. So if you're a COPD patient, when you go up to altitude, the air is much thinner, your requirement is much more. So if you're on nasal prongs on the ground, you will require 6 liters in the air. If you're 6 liters on the ground, you will require non-invasive ventilation in the air. If you're on CPAP on the ground, you will require intubation and full pressure monitoring throughout the entire trip. Yep. So problems with oxygen transport, problems with pneumothoraces, problems with hyperbaric patients or patients with decompression illness, problems with intraocular penetrating injuries will give you huge, huge problems when you don't think of them. So you might have to fly at a lower level. That means sea level, which is around 13,000 feet. So flying at sea level is safe for most of your patients. But more fuel, costs more time, takes a heck of a longer route sometimes. You can avoid mountains, obviously. So all these things come into play when you're transporting patients. G-forces, you might not think of them very much, but when you're rolling around in turbulence with your monitors flying, maybe not flying, so you don't want them to be flying, but wires and sometimes catheters fly off from place to place, things get dislodged, and the noise and discomfort is equally unbearable for some. When you're already sick, it's quite terrible to be moved around from place to place, and noise and discomfort and claustrophobia doesn't really help you. So we employ benzodiazepines liberally where we come from. The good news is that children love noise and turbulence, and they love that kind of vibration that comes into it. Now, I thought I'd had so much problem transporting kids, but one of these guys told me they love these things. And why they love these things is not because it's a nice and wonderful thing that flies around, is that there's so much vibration in a chopper, and this is a medical chopper, that they go to sleep. Believe it or not, they go to sleep. So most of the kids that are transported in a chopper like that, they're just lovely transports. It doesn't matter what kind of injuries they have, just give them a little bit of analgesia, and they go to sleep. It's amazing what vibration can do for you. So, and I mean that in the purely medical sense. Shame on you. Loading in a medical chopper is straight through like that. You can only carry one patient, obviously. Medical choppers are outfitted to have only the essential services. They are quick to get up and down. They can land in nice little places, but they can't travel too far. So they're half the speed of a propeller jet, a quarter of the speed of a jet, and they don't go very far without refueling. So you lie your patient out in like this. That's a flight paramedic. He's a South African gentleman, very, very experienced, and he is the one who likes to winch down and get patients from wherever you are. I was and not fit and never will be that fit, but these guys do all the serious work, and you do the medical part. Two co-pilots in front there. You get your infusion pumps lined up over here, chest drains, trauma kits all here, oxygen up there, patient stretcher across, you hang your ventilator over here, and your infusions can sometimes be seen over here, but they're much clearer there. So you lie them across, and you sit here, and you deal with the airway and other problems that arise. It's fast transfer. Once again, it goes up and down very quickly, so you can't have your barometric problems with it. So you can't take your pneumothoraces into something in such a quick height. You can, slowly, But generally, anybody with a penetrating problem or pneumothorax, you definitely have a chest drain in before you do any aeromedical maneuvers. Yep. So those are the complications that you must think of. So that's the problem with choppers. We don't have much chopper stuff happening here, apart from the SAF that does it from time to time, but those of them don't have any pressurization issues whatsoever. The other thing about choppers is that it's cold. You can see that it's not closed. And when going at night, if you're a problem in the rain, you get really, really cold. Even in Singapore, you get cold. And for that, you got to be prepared for a few things. A Hewitt, right at the bottom, is, anybody know what a Hewitt is? It's a course. Anybody heard of a Hewitt? No? David, who's talking later? No? A Hewitt is something interesting which I'll never forget, and nobody should ever forget. Before you enter a chopper, in most places in the world, you have to go through helicopter underwater escape training. That's what Hewitt stands for. And basically what they do is they put you into a machine to see whether you can swim, and then they dunk this machine, and then they rotate it 180 degrees to simulate a chopper overturning and falling into the water. And that's what everybody has to do if they fly in a chopper for work, right? If you're going to an oil rig, if you're working in the middle of nowhere, if you're working on a ship, you need to go through this training. So that's you sitting down over there, and then you have to learn how to kick open the window, and it's overturned, and you're disoriented, and you don't know what the hell's going on. You're supposed to come out and jump out, well, not jump out, but swim out and go to the surface. So that's what a Hewitt is. So it's not for somebody who can't handle great turning like that and can't handle water very well. And it's cold water as well. So there you go. Something more plush than a chopper and underwater medical training. These are what medical jets look like. So we had the opportunity to have one before I left there. Double the speed of a normal propeller plane, goes very far, has a toilet, which is always nice to have. And that's what a medical jet looks like. This is what we have in Singapore. We mostly fly Lear jets. This is the only picture of me you'll see. And the Lear jets tend to do a pretty good distance very, very quickly. And this is something that you don't expect sometimes. So the jet is very comfortable, plush, even has a TV. Yes, I know, it's a great life until you get to where you're going. This is somewhere near the North Korean border. And the ambient temperature is negative 25 in the day. The ambient temperature is negative 25 in the day. This is just to demonstrate the futility sometimes of putting stuff outside. Nobody told me in my entire career that normal saline freezes at negative 23. I was under the impression that salt water doesn't freeze, because that's why you put salt in water. But normal saline freezes at negative 23. Now, the only person that I know who knew that was this gentleman right here. And he'll talk to you about that later. So when I came back and showed this photograph, he goes, yeah, it freezes at negative 23. And now I know why they call him the professor. Because this had to be put into a microwave for us to give my critical patient some fluids because she was in a state which required some. So there you go, things that you never ever think of. Salt water can freeze. There are other challenges that you need to be aware of. Most of this stuff is done via conferencing, so you need to be managing your patient over thousands of kilometers over the phone sometimes. It's not easy, but it takes a little bit of practice and it can be done. You're always working in distances. This is Western Australia, and a map of it, and you have to plan where you go with a limited amount of planes. It's all about resource management. X amount of doctors, X amount of pilots, X amount of nurses, X amount of aeroplanes, and flying time. Pilots cannot fly 24 hours a day for the whole year. They need to be scheduled on a roster. They need sleeping breaks as well. So Western Australia is the size of Europe, and it takes 6 hours sometimes to get from one place of the state to the other. And you need a whole team of logistics. Same applies to aeromedical services in Singapore. When you're flying China, you need to plan what you need to plan, how you get there, fuel, transport, visas, airport landing requirements, and all these things before your patient can even get off the ground. Planes need to be refueled, but sometimes when you refuel, you get lovely views. This is a mine site somewhere in the middle of nowhere where we had to thrombolize a patient who was having a heart attack, and sometimes you have to do your critical care business in the middle of nowhere. Middle of nowhere sometimes is not middle of nowhere. It's the middle of somewhere which has patients near it, but you have to fly into a place where it might not have an airstrip. This is a dirt track. This is the daytime shot of where we landed, but the nighttime shot was somewhat different. When we were flying over it, somebody said, and we were flying for a while and circling the airstrip, and I go, why aren't we landing yet? Well, we have to wait for the Rushu. Say, what? The Rushu. And say, I know I've been here only 5 years, but what the heck is a Rushu? Anybody? Thank you very much. There are some Australians in the audience, obviously. So when you're flying at night, it's nice and warm in there, but on the ground it's cold, except the tarmac. The tarmac is warm. So when people come into the warm tarmac, well, we don't come in, but the kangaroos and all the other animals come in because it's warm. And when it's warm, they tend to bang into your aircraft. And kangaroos can destroy your aircraft. So what they do is they take the ambulance and they run 3 or 4 times and they shoo the roos away. And that's what they call a Rushu. I'll skip ahead for a while just to go the other things. You need flexibility when things go wrong. That's what Aeromedical and ED is all about. This is a problem that happens not in the aircraft, tire puncture. Luckily, patient was already in hospital. So things go wrong. This is a 180 kg trauma patient, which we could not load into our aircraft. Why? Because the hydraulics that lift the bed and the stretcher and the monitors can only take 150 max. So we had to get the local fire department to get 6 strong firemen to support, and that's my other consultant, and 3 of us, and 8 of us lifted him up and loaded him into the ambulance. So that's air ambulance with trouble loading. So weight is a concern. And aircraft do not fly like that. And they don't. They certainly can't land like that. So you have to weight the aircraft and change things so that they land in a proper fashion. Things sometimes get wrong. This is a trauma patient with what we call a mobile ICU earlier. Everything that you want in a trauma patient is there. Intubated, central line, CO2, infusions, blood, everything going, catheter, all being monitored at the same time with a vacuum mattress to keep them closed. Unfortunately, things sometimes happen which are completely out of your depth. This is a neonate. Neonate are not from the planet Earth. They have completely different physiology, anatomy, moods, swings, temperature requirements, glucose requirements, and I know nothing about neonates, but thankfully, my nurse knew everything about neonates. And we kept them in a nice little thing, and thank heavens I did not have to open that box and touch that alien, which grows up to be a human being. I don't know how. Don't play with neonates. Finally, just getting to the last part of it, this is when Mass-Casualty comes together with Aeromedical. There was a refugee problem with a boat being blown up in the north of Australia, halfway between Java and the north of Australia. We had a call where people were dead, children were burnt, and the nearest burn center was 3,000 kilometers away. There was an air base, or a military air base, there. So just off the north coast. And we had to accommodate that by moving people across. How do you get them there, all the way here, and Sydney, which is further away, about 5,000 kilometers that way. So this is when everything combined, because it was tactically well and strategically well planned. This is the view of the boat. There is a naval destroyer that was streaming on the pass, looking at the boat. And the naval destroyer saw in the top right-hand corner a boat burning, and that's how they first knew about it. People were transferred onto a passing freighter, and they were winched from the passing freighter using the crane, and they stayed on that freighter for about half a day before we arrived. So I wasn't there, but these are some of my colleagues. This is what Mass-Casualty Triage looks on the back of a ship. So is it a mass casualty? Yeah, absolutely. Your resources are completely outstripped, so of course it's a disaster. So this is P1s, P2s, and generally no P3s. So all of them were kept and looked after. Critical patients, burns, severe burns, inhalation injuries, blast injuries, and looked after on the back of a ship. At the top of the ship, which is about 2 stories up, they were escorted to a helipad. You can see that there's tertiary burns going on, and the tertiary burns guys had to walk all the way to the chopper. So these guys can do stuff. They've been all the way from their country on a boat for a while. They got burnt, and they can still walk up onto a chopper. Moved across into critical aircraft to Perth, And that's what the critical transfer of a burns patient looks like. So why? Why do we do it? It's the same reasons we do ED, though. It's the same kind of environment. It's just less people and less resources. But it's challenging. But that's why we like it. It's not because we don't like it challenging. We like it because it's challenging. It's the same thing we do in ED. It's variable, it's flexibility, it's shift work, it's everyday applicable research. What do I mean by that? Things in the wild. This is our trip, well, not trip, but our relief mission to Nepal in the earthquake. And we're using critical care to solve the problems. How? Peripheral dose infusions of vasopressors, fluid management via ultrasound, point of care ultrasound, early goal-directed therapy. All these things used in an environment which you're not used to, in casualty situations, and that's what we do. If you'd like to join us, let us know. Those are my references. Thank you for listening.
Thank you, Rahul. That was really, really interesting. So next, for the talk on resuscitation in the wilderness, I'd like to invite Dr. Kanak Naidu, who is currently a consultant in emergency medicine at the Kotekpwat Hospital. He's double board certified in internal medicine and emergency medicine, and he was trained at the Louisiana State University and the Medical College of Georgia. So his niche in emergency medicine includes ultrasound and wilderness medicine. So let's invite him to